Geriatrician in the Department of Family Medicine here at the University of Iowa. I have the opportunity today to speak with you about Parkinsonism and a geriatrician's perspective on Parkinsonism. The objectives of the talk are to describe a multidisciplinary and a functional approach to Parkinson's disease, to discuss the diagnostic criteria for Parkinson's disease, then compare some conditions misdiagnosed as Parkinson's disease. I'll list some drug and non-drug therapies, and then conclude with recommendations for practice. I need to start out by saying that I have no conflicts of interest or financial disclosures. There is some data out there in the literature regarding smoking as a protective factor, reducing the risk of Parkinson's disease. But in spite of that data, I do not recommend smoking for anyone, and especially as a preventive practice for preventing Parkinson's disease. So some of the faces of Parkinson's disease. Here we see Muhammad Ali and Michael J. Fox. This kind of goes against the demographics and the epidemiology of Parkinson's disease. We know that Africans and Asians have the lowest prevalence and incidence of Parkinson's disease. Caucasians have the highest incidence of Parkinson's disease. And African Americans have less than Caucasians, but more incidence than their African counterparts. What's different about Michael J. Fox is his youth in developing Parkinson's disease. This is typically an older person's disease, and there's actually an exponential increase in incidence of Parkinson's disease from age 65 to age 90. Janet Reno, the first woman to serve as a U.S. Attorney General, is another individual stricken by Parkinson's disease. She's a little unusual because the incidence of Parkinson's disease is higher in males than in females. There is some data or some hypothesis why this may be. One is that males may be exposed to some toxins in the workplace that females are not exposed to. My particular theory is that the female partner is more likely to bring her male partner to the doctor sooner than the other way around. I'd like to take a broad view of Parkinson's disease, and this is a new multidisciplinary approach to an old actor. We see that the disease process can be divided into three stages. One is a premotor phase. The next is the clinical evidence phase, when we typically diagnose clinical Parkinson's disease. And then the final stage is Parkinson's disease with complications. As a geriatrician, I look at these phases similar to as a pre-frail stage, or frail in situ, in the premotor phase, frailty in the specific motor symptom phase, again, where people develop a loss of homeostasis. So a little insult as far as a disease process or other psychological insult throws the homeostasis off and people cannot recover. Then finally, an activities of daily living disability phase, which would be consistent with Parkinson's disease with complications. In that aspecific non-motor symptoms, we have such things as difficulty with the sense of smell, constipation may be a complaint, depression, problems with joint pain, fatigue. People may present with orthostatic hypotension. And as you can tell by these general complaints, it would be very hard to pin down a diagnosis of Parkinson's disease, or maybe even to consider Parkinson's disease at that stage. It's something to keep in mind. Specifically, depression may develop well in front of motor symptoms in Parkinson's disease. The clinical evidence stage, when we make the diagnosis from clinical symptoms of Parkinson's disease, may take a couple years of symptoms before we even make the diagnosis. The symptoms have to include bradykinesia, or slowness of movement, and then one of the following, either rigidity, tremor, or postural instability. Following several years, and usually many years, this individual goes from the specific motor symptoms into aspecific non-motor symptoms that are specific in the geriatric setting. These would include that memory impairment, which may be present in up to a third of individuals, depending upon how you measure memory impairment in Parkinson's patients. Sleep disorders are very common. Acute delirium, especially if someone is in an unfamiliar environment like the hospital, very easy to develop delirium in the presence of an underlying Parkinson's disease. Nocturia can be present. Again, we need to remember the bladder is a muscle that can become stiff. The detrusor muscle may not have the same capacity to store urine, and this can lead to increased urination and lead to nocturia. Dysphagia with pneumonia is another complication of Parkinson's disease. The most likely reason an individual dying from Parkinson's disease is usually from bronchopneumonia or respiratory problems. A lot of times this is related to aspiration. Along with these particular phases, we actually see changes in the brain that corresponds to the different clinical symptoms. In the first phase of clinical symptoms of premotor, or the premotor phase, the lucus coeruleus, the dorsal 9th and 10th nuclei are affected, again leading to those symptoms of difficulty with sense of smell, depression, articular pain, and on down the line. As we get to the clinical phase, where we have the symptoms of Parkinson's disease and make the diagnosis, this is where the mesocortex and the substantia nigra, which has always been the focus of Parkinson's disease in the brain, impact these symptoms. We've known for a long time that the pigmented cells in the substantia nigra decrease with Parkinson's disease, and the ability to produce dopamine is reduced. In the final stage, the neocortex and the cortex is affected, again leading to problems such as memory, sleep disorders, and on down the list. We don't have a gyroscope. It's not in production yet. Dr. Zeus has imagined this particular instrument, and as long as we don't have an instrument like this, we're just going to have to use our brains and our clinical findings to make the diagnosis of Parkinson's disease. So what do we need for the diagnosis? There's no biological marker to confirm the diagnosis. The diagnosis in a lot of instances is not made when it's present, and a lot of times it's an incorrect diagnosis made of Parkinson's disease. Those classic symptoms are tremor, rigidity, bradykinesia, or slowness of movement, and postural instability. The best way to distinguish Parkinson's disease from other Parkinsonisms is by Parkinson's disease typically is asymmetric. It may start in one hand, it stays worse on that side of the body, and remains asymmetric. There is a resting tremor in Parkinson's disease in most cases, and there's good response to levodopa. If all three of these findings are present, the likelihood of Parkinson's disease versus other Parkinsonisms is highly likely. Features that would suggest an alternative diagnosis of Parkinson's disease would be if the dementia precedes the motor symptoms. In the first 3 years, if an individual develops postural instability, freezing, hallucinations that aren't related to the medications they're taking, we need to think of things such as Lewy body dementia causing this Parkinsonism. Supranuclear palsy is another diagnosis that may be missed and diagnosed as Parkinson's disease. The key to this diagnosis is drug-induced downward gaze. An individual may present with symptoms of visual impairment. If you check their visual acuity, it's perfectly normal. If you ask them to read, however, they have a stiff neck, they may not be able to bend their neck down or move their eyes down to read the newspaper. In this downward gaze, the difficulty would be a significant finding leading to the diagnosis of supranuclear palsy. With the aging process, there is a little decreased ability to look up. There shouldn't be any effect on downward gaze with the aging process. The good thing about this diagnosis, if there's anything good about it, prisms can take care of that problem with visual impairment. That will focus the vision down in the presence of a stiff neck. The person still can do their activities, again, which is mostly right in front of them at the desk where they're working. Severe symptoms of dysautonomia, that individual who you try to get up from the exam table, and every time you do that, they pass out because their blood pressure falls so rapidly, will be a sign of Shy-Drager multiple systems atrophy, which isn't typical Parkinson's disease. It runs a much faster downhill trajectory. The diagnosis of plausible other causes of Parkinsonism, such as a focal brain lesion or a person being on neuroleptic, will help us with the diagnosis that this is not Parkinson's disease. Those conditions misdiagnosed as Parkinson's disease will include essential tremor. Essential tremor is very common in the older population, and this might be the first thing to come to mind that this is Parkinson's disease. We'll talk a little bit more in depth about how to distinguish essential tremor from the Parkinson's disease tremor. Vascular Parkinsonism, in the setting of a person with underlying vascular disease or disorders, a person with strokes, for instance, may present with movement disorders. We can think of vascular Parkinson's disease more as a lower extremity Parkinsonism that seems to affect the lower extremities maybe more than the upper extremities. Drug-induced Parkinsonism, any antipsychotic medication can lead to symptoms of Parkinson's disease, the dyskinesias that you can get from those disorders, the stiffness you can get from taking those medications. One of the things to keep in mind is metoclopramide, Reglan medicine that we may give for reduced gastric emptying, for instance, in someone with diabetes, may have the same effect as other antipsychotics and lead to Parkinson's or Parkinsonism. And this is one we can cure by discontinuing the medication. Dementia with Lewy body disease, the typical symptoms of Lewy body dementia is early in the course of the disease. There's visual hallucinations. There can be visual hallucinations later in the course of Parkinson's disease. It's fairly atypical early in the course. So if there is visual hallucinations, think about the diagnosis of Lewy body dementia. Atypical Parkinsonism, we've talked about already, supranuclear palsy with the difficulty with downward gaze, and multiple systems atrophy where there's severe autonomic nervous system dysfunction, and the downhill trajectory is quite steep, and these individuals don't respond typically to the levodopa therapy, which the Parkinson's disease patient would respond to. So what are the clinical features? We talked about the tremor. The tremor in Parkinson's disease is typically a 4 to 6 hertz cycle tremor. It's prominent in the hands, but the absence of tremor doesn't rule out the diagnosis of Parkinson's disease. It may be absent in up to 25% of individuals. We need to distinguish that Parkinson's tremor from essential tremor, which is fairly common. The age of onset in Parkinson's disease, as we've already stated, is later in life, and the main onset is usually between 55 and 75 years of age. Essential tremor can start very early in the lifespan, at 10 years of age, and can even come on later in life at 80 years of age. There is little familial history with Parkinson's disease, whereas there is a very strong familial history with essential tremor, again known as familial tremor. The frequency of the tremor also is somewhat different, whereas the Parkinson's tremor is a little bit slower, 4 to 6 hertz, the essential tremor a little bit faster, 5 to 10 hertz. The characteristic of the tremor, typically the Parkinson's tremor is a pronation supination or pill rolling tremor. There's more of a flexion extension tremor in an individual with familial tremor. At rest, the tremor is much worse with Parkinson's disease, and the essential tremor improves with resting. Writing is decreased, and typically we see micrographia with Parkinson's disease. An individual with essential tremor may have a very tremulous, erratic writing characteristic, whereas that Parkinson's patient, it gets smaller and smaller as they go on, and their writing may fall off the page or go down the page. As far as body location for the tremor, you can have face, jaw, lip, and chin tremor with Parkinson's disease. But typically, essential tremor will affect head bobbing, called titubation, and a voice tremor. In Parkinson's disease, there typically is not a tremulous voice, but maybe a very soft voice. We find from studies of the vocal cords that there's bowing of the vocal cords in Parkinson's disease. Thus, they really can't express themselves loudly, whereas in essential tremor, there's more vibration and a tremor in the vocal cords. Rigidity is one of the other cardinal symptoms of Parkinson's disease. There's increased tone throughout the whole range of motion. This is usually increased with the limbs in moving them. By itself, it's not disabling, and it needs to be distinguished from spasticity. That individual who has had a stroke, when you move their arm, there may be a loose period before you get to this period where they become very rigid and start ratcheting. Whereas in a Parkinson's patient, through the full range of motion, there's rigidity. If we place the tremor on top of the rigidity, this is where we get cogwheel rigidity. And if you ever actually measure that rigidity, it will correspond with the frequency of the tremor. Bradykinesia is one of the more disabling symptoms for Parkinson's disease. There can be delay in the starting of movement, slowness and poverty of movement. There's a thing called a threshold phenomenon. An individual may be walking into a room, sees the threshold, and they just get stuck. That's part of that bradykinesia. You can tell family members who might accompany them just to hold onto their shoulders and back of them and rock them back and forth, and this will allow them to step off and get over that threshold. There can be an arrest of ongoing movement. Someone can just be walking down the hall and all of a sudden they just stop. Where this becomes a big concern is in settings where a person is rushed. We may rush an individual in taking a history. We may think that they're demented because they can't give us an answer, but maybe we just didn't give them the time and they didn't have the motor speed to give us the answer to our questions. So we have to take our time in taking a history from the Parkinson's patient and take into account that they may be bradykinetic. Another place where this becomes very difficult is with nutrition. For instance, in a hospital setting, where a tray is placed in front of someone and a half hour later, someone comes by and picks up that tray of food. It may not give that person with bradykinesia the time to actually take in the calories that they need. So that needs to be a consideration. The time that it takes to dress oneself can be very disabling if it takes you an hour every day just to get your clothes on or to bathe yourself. The final general criteria for Parkinson's disease is postural instability. That's the inability to maintain equilibrium, the inability to react to abrupt change in positions. This can be checked in a clinical setting by doing a shoulder tug to see if you can knock someone back. Make sure you don't allow them to fall, and make sure you reassure them that you won't let them fall before you do a procedure like that. They may have difficulty stepping back and have the proper righting reflexes to adjust their center of balance. This is a picture of a Parkinson's gait. The individual is bent forward. There's a shuffling of the gait. People like to have both feet on the ground as long as they can, so they keep their feet close to the ground. An individual can be easily knocked backward, propulsion or retropulsion, or knocked forward. Someone can come up to a Parkinson's patient and slap them on the back and say, "How you doing, Joe?" And that may send them out into space because they can't control that center of gravity. This may lead to festination of gait. We see the far right picture here, an individual who's bent forward, the center of gravity is out in front of them, and they keep taking faster and faster steps, trying to catch up to their center of gravity until they may run into something and eventually fall. So how do we communicate with our colleagues about the level of functioning of individuals with Parkinson's disease? And this is where the modified Hoehn-Yahr scale comes into play. The first stage of the Hoehn-Yahr scale is where there's no signs of disease. So you might ask, well, how do you know that you have Parkinson's disease if there's no signs of the disease? This would be in an individual that has had signs of disease. They begin treatment, and those signs have disappeared. This individual will be functioning well, and there's no apparent functional impairment with this individual. The stage 1 of the Hoehn-Yahr scale is unilateral disease. The individual that may have just a unilateral hand tremor, the first symptom of onset of the Parkinson's disease. Stage 1.5 is where there's unilateral changes plus some axial skeletal involvement. So you may, on your physical exam, move their neck back and forth and pick up on some rigidity in the axial skeleton. Stage 2 is bilateral disease, but balance is still intact in this individual. So there's no problems in this individual with activities such as walking, no history of falls in this individual. Stage 2.5 is there's bilateral disease, and when you do a pull test or a shoulder tug test on this individual, they can recover from it. It may take several steps before they can recover from a movement of their center of balance. Stage 3 is postural instability. This individual still remains independent, but they're wobbly, they're predisposed to falls. A quick disruption of their gait may lead to a fall. Carrying the laundry upstairs when they've lost their balance beam or their arm swing, that may lead to falls because of this postural instability. Stage 4 disease is where severe disability occurs. The individual is still able to walk, but they're severely hampered in doing their activities of daily living. And then finally, stage 5 disease is this individual is wheelchair or bedbound. So how do we treat Parkinson's disease? Again, some individuals that need treatment. The first thing we have to decide is when to start therapy. And some of the things to consider in starting therapy is the dominant hand affected with the disease process? So we're always thinking about function in making this decision. If the dominant hand is not impacted, maybe we can delay treating this particular illness. Is there significant bradykinesia or gait disturbance? Again, this person may have a great risk of falling or breaking a hip, leading to their demise. What is the personal philosophy regarding drug use in the individual patient? But again, the bottom line is the degree that the disease is affecting functioning. And we really don't want to delay treatment, because we know if we delay treatment, there's a longer period of disability that the individual will be suffering from, and we haven't gained anything by that delay other than reducing their function. As far as protective therapy, there's no proven treatment to really slow the progression of Parkinson's disease. Saligeline initially was thought to maybe be a protective medication, but then it was found that it actually ameliorates symptoms, and there is a question of increased mortality with the use of this drug. So there's really no indication for the use of saligeline. High-dose vitamin E has been checked, and that has been found to be ineffective in protecting against Parkinson's disease. So symptomatic treatment, again, using that pill sandwich, what are the symptomatic treatments that we can use? Levodopa remains the most effective treatment for Parkinson's disease. The form of levodopa that's typically used is a combination with carbidopa. The trade name is Sinemet. There's good marketing for this particular drug because all you Latin scholars out there know that sine means without, met means without emesis or without nausea. So they named this medicine because the carbidopa reduced the peripheral side effects of levodopa, so people could tolerate this medicine that was now more developed and prevalent in the CNS rather than in the periphery, which benefited patients greatly without the side effects. Most patients will benefit from Sinemet or levodopa carbidopa throughout the entire course of their illness. There's no evidence that this accelerates the neurodegenerative process. It increases life expectancy, and survival is reduced if the drug is delayed until there's great disability. Other symptomatic treatments includes anticholinergics, such as Artane. The difficulty with the use of anticholinergics, the population that's mainly affected by Parkinson's disease is that elderly population, and they're more susceptible to the side effects of anticholinergic medications. An individual with benign prostatic hypertrophy, we may throw them into urinary retention, giving them anticholinergics. A person that may have a little bit of confusion to start out with, we're going to make that a lot worse with using anticholinergics. Amantadine is another medication that has been found effective for Parkinson's disease. This was discovered by accident, treating individuals with influenza with amantadine that also happen to have Parkinson's disease. Their symptoms improved, so it became a treatment for Parkinson's disease. Saligeline we mentioned before. Rasagiline probably is a good substitute, an MEOB-I inhibitor to take the place of saligeline, and this could be useful in mild disease and be very beneficial, and can be used also with levodopa and dopamine and agonists, and it does reduce disability. Talcopone, a COMP inhibitor, can also be used with levodopa carbidopa, and if you do use talcopone, you need to remember to monitor liver function tests, which may be affected by this medication. Other treatments, dopamine agonists, can maybe provide some benefit in about a third of the patients that have good response. It's usually used as supplementary treatment to levodopa. But by itself, there are certain individuals that may benefit from 2 to 5 years with this medication. There's less frequency of fluctuation with the dopamine agonists and less dyskinesia than with levodopa carbidopa. It may become very confusing for the patients. We have to remember that this individual with Parkinson's disease may have motor disabilities to be able just to manage a pill bottle to can pick up a pill because of their tremor and their rigidity, and also to remember what medications to take. So we also want to make sure that caregivers are helping monitoring the medication use. If the patient needs assistance, we want to make sure that that's available for them if they're getting the medicines in that are prescribed. Dopamine agonists that we've already mentioned include bromocriptine. There's no use for bromocriptine. This has been associated with lung and cardiac valve fibrosis. So non-ergot dopamine agonists can be used as first line and adjunctive therapy for Parkinson's disease. Propinerol, pramipexole, rotigotine are all medicines that can be used. Rotigotine can be used as a patch, it's in a patch form. So an individual is having difficulty remembering to take medications. This can just be applied once a day. It may be very beneficial for that individual that may have cognitive disorder. So what about late stage disease and problems that come with that? About 70% of individuals by 15 years of the disease will be suffering from motor fluctuations. There can be a wearing off of the drug effect. The levodopa initially, the drug level will go up and down, but the functional benefit from that drug level going up and down is sustained for a long period of time in early disease. As the disease progresses, the functional improvement with the levodopa corresponds more with the drug level. So the drug level goes up and down and function goes up and down. Therefore, the medication, the levodopa, has to be given more frequently to overcome that reduced effectiveness, long-term effectiveness of the medication. Individuals can also suffer from an on-off phenomenon, that all of a sudden the switch just goes off like that and they stop moving. And this is something that can be anticipated well into 15 years of the disease process. Dyskinesias may respond to amantadine. There may be a peak dose effect of dyskinesias. I think that you may have seen individuals on television, such as Michael J. Fox, that have some movements that aren't controlled as they're being interviewed. This is a sign of dyskinesia. When an individual has the peak dose of their medication, they may get dyskinetic, or as they go in and out of therapeutic range of their dose, they may get these abnormal movements. And they also may have dystonia, where the muscles are just very rigid during times where the medicine wears off. Amantadine is one of those treatments late in the course of the disease that may be helpful with dyskinetic responses. Psychiatric disturbance can present in late disease. An individual can have vivid dreams, visual hallucinations. Again, we talked about Lewy body dementia. Those visual hallucinations typically occur early in the course of illness. Vivid dreams and visual hallucinations may be related to the medications. We do have control over the medicines, so all we can do is lower the medications and see if those symptoms resolve. And then we have to deal with the functional consequences of the reduced functional mobility an individual may suffer from those lower medications. Mania may develop, hypersexuality. Paranoid psychosis is another psychiatric disturbance late in the course of Parkinson's disease. So who's a surgical candidate? Deep brain stimulation can be used in individuals that no longer can tolerate the dyskinesias. The motor fluctuations are so severe and they're not controlled by levodopa therapy. Appropriate candidates should have their cognition intact, and usually they're less than 70 years of age. So these are typically individuals that I don't see as a geriatrician. So there's little indication for my particular population of those 75 plus or 85 plus individuals that I see in my practice. So we need to weigh the benefits and the risks of deep brain stimulation. The benefits is we can reduce levodopa doses and improve the off-medication function of an individual with the use of deep brain stimulation. There's also reduced dyskinesias when the person is taking the medications. We need to weigh that benefit against the risk. The risk includes increased depression in individuals with deep brain stimulation, decreased verbal fluency, increased falls and impulsivity that may come with these surgical procedures. So how about non-medical functional assistance? How can we help Ozzy Osbourne here with some non-medical help? So support services are very important. The usual elder services are very good for both the patient and the caregiver. We need to always be concerned that we're watching after the caregiver as well as the patient when we're dealing with chronic diseases. There's specific disease-oriented organizations, and I've listed a website here for some of those organizations, and they have valuable information on treatment options, usually research protocols that are available, and also help with the caregiver anxieties and depression that goes along with caregiving. Physical therapy has been proven to reduce disability in Parkinson's patients. Occupational therapy, specifically home interventions, may help individuals stay longer in their home, be more functional, more social with the family, and this is something that can be sustained a little bit after the intervention itself of the occupational therapy. Speech therapy has been used. Intensive therapy for 2 weeks can improve voice problems, and this gain can last for up to 3 months after the intervention. There's also a thing called shouting therapy. This is something that I will use with a patient that I'm trying to hear in the office that has Parkinson's disease, because they speak so soft you can't hear them, like you can't hear me now, and you just ask them, please yell, and as they yell, their vocal cords will oppose each other better, and you can actually hear them when they're yelling. Another thing that I don't recommend, but you'll see it happening if an individual has an upper respiratory infection, they have some swelling of their vocal cords, and they come together easier when they have an upper respiratory infection. So you maybe hear them better when they're congested. So what are some of the assisted devices that we can use to improve the function of individuals with Parkinson's disease? This is an example of a button hook that can be used. An individual with Parkinson's disease may have difficulty picking up small objects or working a button on a shirt. Velcro, of course, works, but you really can't find a fancy shirt with Velcro, so you may need to use a device such as a button hook that can grab the button and pull it through the shirt to button your shirt. Weighted utensils are very important. As we remember, the tremor in Parkinson's disease is a resting tremor. So if they have to use their muscles more because of a weighted utensil, there's going to be less tremor there. And that way they can feed themselves, so when they come to their mouth with a weighted utensil, there's less tremor. They can get more into their mouth than on their lap. Another important assistive device is a wheeled walker. And typically what we recommend is a front-wheeled walker rather than a four-wheeled walker. Remember, with Parkinson's disease, an individual can develop festination of gait, and with a four-wheeled walker, they may be just sent off in space. There's no way to stop them, and they probably can't really institute a braking mechanism before they run into something. So a front-wheeled walker, where an individual can just push down on it to reduce speed, is what's typically recommended for a Parkinson's disease patient that has postural instability. The Cadillac or the Mercedes of walkers is the U-step. So if you have $700 or $800 and can afford the U-step, this is probably the ideal walker for an individual with Parkinson's disease. We see that there's a seat there, so if you lock this the device at the handles there, you can turn around and sit down if you get fatigued. There's also a laser across the bottom by the wheels there, and this particular laser can stimulate an individual to step over that light source. And we find that an individual will be stimulated to pick their feet up better. There's less festination of gait and less likelihood of falling because they're picking their feet up. Another assistive device that I don't have listed here is a Walkman or an iPod, something that you can play music. Marching music has been found to be effective in individuals with Parkinson's disease. There's a different part of the brain that's stimulated with the marching music, and they can march along with the music and pick their feet up better. There's less festination, less shuffling of gait, and they can exercise better if they're exercising to their marching music. So what are the recommendations for practice? First recommendation is that carbidopa-levodopa, or a non-ergot dopamine agonist, should be used as first-line therapy for an MAO-B inhibitor. The non-ergot dopamine agonist, COMP inhibitor, and MAO-B inhibitor can be added to levodopa to treat motor complications later in the course of the illness. This recommendation is based on good quality patient-oriented evidence. The second recommendation is the use of amantadine for dyskinesias in advanced disease. Deep brain stimulation for functional impairment despite optimal medical management, but again, keep in mind these individuals have to have their cognition intact, and usually they have to be younger than 70 years of age to benefit from this procedure. Physical therapy can improve gait, and speech therapy can improve speech volume. The level of evidence is inconsistent patient-oriented evidence for these recommendations. Final recommendation for practice is physicians with limited experience should refer patients to confirm diagnosis. But keep in mind, if an individual has an asymmetric tremor, so the disease is worse on one side, they do have a hand tremor, and giving them 25, 100 carbidopa-levodopa, and they respond to that, that's a pretty good indication that you're dealing with Parkinson's disease. Occupational therapy may help patients maintain family, social, and work roles. They can continue to perform their activities of daily living, and you can improve safety with the use of occupational therapy. This recommendation has been based on consensus and usual practice and expert opinion, as well as case series. I think it's very important, and I've mentioned this before, to consider the caregiver when we're dealing with a chronic disease such as Parkinson's disease. And when you see a Parkinson's patient, remember who their partner is, and they become your patients in some ways too, even though they may not be your official patient. We need to evaluate them for their caregiver burden. Are they suffering from depression because of their caregiver role? And how can we support them and recommend community resources to support their activities as caregivers? Also keep in mind that there's a great deal of depression and dementia associated with Parkinson's disease. Up to 50% of individuals with Parkinson's disease will have depressive illness some time during the course of their illness. And as I stated before, even before the onset of motor symptoms, they may develop depressive illness. So it's not just a reaction to the motor changes of Parkinson's disease that brings on the depression. There's neurochemical changes in the brain leading to depressive illness even before the typical motor findings. Dementia is also prevalent. in Parkinson's disease. Again, older population is affected by dementing illness and Parkinson's disease. Parkinson's disease doesn't make you immune to Alzheimer's dementia, and depending upon how you measure dementia, some studies show up to 30% of individuals with Parkinson's disease have an underlying dementing illness. So going back to the original approach and the different stages of Parkinson's disease, we need to consider that premotor phase where an individual may present with non-specific motor symptoms. Keep in mind to be looking for those motor symptoms in those individuals that you see in your practice. Specifically, if out of the blue an individual presents with depression later in life, is this prodrome for motor dysfunction? Maybe ask a little bit more questions about difficulty sleeping at night, maybe related to rigidity that they're experiencing. Have they developed a fine tremor that you can pick up on closer examination? The specific motor symptoms really give us that diagnosis. They have to have bradykinesia to make the diagnosis of Parkinson's disease, and one of the symptoms of rigidity, tremor, or postural instability. And then be very concerned about late in the course of the disease, the motor fluctuations that they experience, the other complications of caregiver burden, and memory impairment that will occur with this disabling part of the disease. That concludes my presentation. I'd be happy to answer any questions. I can give you my email if you have specific questions about the content of this presentation. Thank you for your attention.